And now for part 4 on bias and chance in diagnostic testing. And hopefully you've made it to this point. So thanks for staying online. So we've talked about things like sensitivity and specificity and likelihood ratios and things like that. And all these numbers will be quoted for sensitivity of a certain test, for example, are based on studies. And you have to ask yourself as a consumer of research is what is the validity of all these diagnostic tests? Are they internally valid? Are they externally valid or generalizable? Are there any methodologic flaws in their application or development? Are these tests providing reliable information for you to use in your population? Are these results credible? Because if they're not, there are potential harms to patients, for example, misdiagnosis or unnecessary treatment or missed opportunity for treatment, and of course, cost to system. So the first type of bias we'll talk about is the spectrum or subgroup bias, which is also known as case mix bias. As we said earlier, test properties like sensitivity, specificity, and likelihood ratios shouldn't vary with disease prevalence. But they might, though, in real life. If a test is derived in one population but applied somewhere else, these test properties might change. For example, if the new population has a different age background or racial background, for example, or if the clinical presentation is different, maybe different disease severities or a different pathologic stage, for example, the results may be different for your sensitivity and specificity and likelihood ratios. For an example, ECG stress testing is actually less specific in women than in men. So there's more false positive in women than in men. Why might that be? It might be because of decreased prevalence of coronary artery disease in women compared to men. And so if we have a lower prevalence in a population, a test might more likely be a false positive, for example. So in women, ECG stress testing is actually less specific than in men. And sometimes diagnostic tests are often derived in people who clearly have the condition and are those who clearly don't. But you have to wonder how well does it perform in between for those cases that isn't as obvious to determine if they have a condition or not. So ideally, a test will be derived in a wide range of presentations to make sure it's stable. Reproducibility is another issue. You want to know if the test is going to perform the same way all the time. If a test is done on different equipment, for example, by different examiners in different labs with different reagents, different assays, for example, will it perform the same way? One example for us in the emergency is the HINTS exam used in acute vestibular syndrome. And the HINTS exam was derived initially in very highly trained operators, including neurologists. So we have to ask ourselves, are non-neurologists or people who have not been as well trained at doing the HINTS exam as good at it? Will they be as sensitive or as specific? Another type of bias we'll talk about is the reviewer interpretation bias. The first kind is test review bias. And this is when you have the knowledge of your gold standard result, which influences how you assess the diagnostic test. So let's say, for example, you're in the trauma room and you have a patient come in with a chest injury and you're doing an EFAS and you're not sure if there's a pneumothorax that you're seeing. And so you go and actually check the CT scan results later on, and there's no pneumothorax. And so you go back and say, no, I think my lung scan was negative for pneumothorax. That's test review bias. There's also diagnostic review bias, when the knowledge of the diagnostic test results influences the assessment of the gold standard, so the opposite way. Let's say that you're doing a study looking at the use of D-dimer versus Doppler to rule out DVT, for example. So you're doing the leg ultrasound, compression ultrasound, which is the gold standard test, and you check the D-dimer and it's elevated, and you're not really sure if you saw a clot or not. And so with a positive D-dimer, you go back and you call your scan positive for a clot. Another type of review or interpretation bias is incorporation bias, when the results of the diagnostic test are actually part of the gold standard as well, which isn't ideal because you're using the same information twice and they should be standing separately from each other when it's part of the gold standard. So how do we avoid review biases? As much as you can, blind. So if you know the test result, you shouldn't be looking at the gold standard and vice versa. And don't use the test as part of the gold standard. There's another type of bias known as workup bias or verification bias. And that is when patients with a positive or maybe negative diagnostic test are preferentially selected to undergo verification by the gold standard. So, for example, say the gold standard is very invasive or it's risky and you don't want to subject low-risk patients to it, they won't undergo the gold standard test. And this is typically done for the negative test results, will not get the gold standard test. However, you're probably going to find, though, patients with a positive result on the new diagnostic test who get the gold standard test are going to be more likely to have the disease than patients with a negative result. And patients with a negative new test result won't get the gold standard, but they can still have the disease, unfortunately. And they might be erroneously labeled as true negatives, but if it had been worked up fully, they would have been false negatives. And this will overestimate your sensitivity, but we're really underdiagnosing in reality because we're actually missing a bunch of false negatives. So how to minimize this type of bias? If you're doing a prospective cohort study, if you can, make sure all patients undergo a gold standard or confirmatory test. But if it's too risky or maybe not ethical necessarily to submit everyone to it, observation itself can be the gold standard, and you'll follow people forward through time to see if they have anything related to the condition you're testing for. For example, if they died or not, or developed some other condition or not. In retrospective cohort studies, this might not be possible though. In retrospective studies, the only data you have is what's collected, so this may not be possible. But it is possible, however, to use statistics to predict the outcome in those who don't get the gold standard. Maybe your next best thing to do. Confounding is another type of bias that can arise in diagnostic testing. And what if you're measuring the wrong thing? So for example, let's say that you have someone with a fever and you're in a tropical area and you're looking to see if gametocytes in the blood can diagnose malaria. So gametocytes themselves don't cause malaria, they just hang out in the blood after malaria is over. But if you're measuring them, you may be measuring something associated with that, something else that's causing the fever. And so you're measuring the wrong thing actually. And so using gametocytes is not a valid test for malaria. There are also some temporal biases. The first type we'll talk about is something called lead time bias. And that is when screening appears to lengthen survival time. And you think that screening has made a difference and has increased survival time, but it really hasn't. And let's go through some diagrams. So in figure A here, let's say this person gets a disease in the year 2000. The usual time for diagnosis based on the natural history of this condition is about 7 years after, and they die unfortunately in 2010 because of it. Let's say now we can screen for this condition, and let's say it gets picked up in 2004. So now it looks like we have a 6-year survival compared to the 3-year survival from 2007 to 2010 in panel A. Now let's say, however, screening really doesn't actually increase survival time. It just increases the length of time a patient knows about the diagnosis. This is called the lead time bias. So it appears that survival has increased survival, but it really didn't, if it's true that increased screening has no difference on the outcome. But if we don't know that picking it up sooner does not change the progression of disease, it appears to make it look like screening is actually beneficial, when really all it did is that increase the length of time we knew about the diagnosis. There's also length bias, which is illustrated by an example when screening tests are better at finding slower progressing diseases like slower growing tumors, for example. In a slower growing tumor, you have more time before symptoms develop and you have a longer asymptomatic period. And if it's a slow growing tumor, it may not cause problems for many years. Versus faster developing conditions like faster growing tumors are less likely to be picked up by screening because they have a shorter asymptomatic period. So it makes it look like screening is going to pick up the diseases that have a better prognosis. So it looks like screening is actually beneficial because the prognosis is so good. But really, in real life, the disease, or let's say the slow-growing tumor, was going to cause problems anyway. So whether you pick it up now or later may not change much. Issues like we talked about in the first video, some gold standard issues. What if there is no good gold standard, or what if it's not reliable? What if the new test is actually better than the gold standard? And we talked about this. And what if the new test is better, but it may look like it's worse in comparison, for example? Or if your new test is just as bad as your gold standard, and if you don't know your gold standard is not very good, it looks like your new test is doing all right, but it may not be, unfortunately. It's also very important to remember publication bias and remember there's no journal of negative studies. Just because there were positive findings as published doesn't mean it's correct necessarily. Chance is also at play. Maybe the results of a diagnostic test study were just due to chance, and if you repeat it somewhere else, you may get very different values. So always remember chance can be an issue. So what do we do? Because there's so many studies that we're seeing all the time in our news feeds or on blog posts or on podcasts, and how do we know these studies are representing reality? So as much as we can, as part of our jobs as being consumers of research, is to be aware of different critical appraisal tools we can use to help us determine how confident we feel about the results. So here are some websites I've listed here, and we'll go over some in the tutorial as well, and which can help you appraise the validity of a study and applicability to your patient population. So in summary, just because something is published doesn't mean it's the absolute truth, and there's many potential threats to validity, including bias and chance. And be aware that every study has its limitations. So thank you so much for watching these videos, and we will see you in the tutorial.